Everyone to this session of the Health and Social Care Select Committee. This is our hearing on the adult social care cost of inaction inquiry. It is our delight to have two illustrious panels for us to question this morning to get to the bottom of some of these numbers. For the benefit of the committee and those watching, may I ask the first panel in order, starting with Councillor David Fothergill, to introduce themselves and what they do.
Thank you very much. I'm Councillor David Fothergill. I am a councillor in Somerset, which is at the end of a very difficult train line this morning. I'm the chair of the Community Wellbeing Board at the LGA, and I'm also a deputy chair of the LGA.
Good morning. So I'm Melanie Williams. I'm an executive director of adult social care in Nottinghamshire, and I'm also ADAS president. Good morning.
Good morning, my name's Hugh Evans and I'm Executive Director for Adults and Communities at Bristol City Council. I'm also the statutory DAS for Bristol City Council.
Fantastic. Thank you so much for being with us this morning. We'll start with questions from Danny Beals, please.
Thanks very much. Just to start in quite a general sense about the funding challenge, which I'm sure will be kind of familiar territory for all of you. Just generally, what impact are you seeing from the current funding constraints around social care, and what's that meaning for your ability to deliver adult social care? Then who wants to start? Melanie?
I'm quite happy to start. So if we think about the impact of it, I think there's, I suppose, 4 lines of inquiry in terms of reform. I think it's useful to think about this. So the first is about our ability to transform models of care. So we're thinking about improving people's outcomes through greater choice, control, self-determination. Then there's the impact on workforce, our ability to reward, recognise, pay, develop and promote our staff. Then there's a bit about our interface and integration, importantly with the NHS, but not solely with the NHS. So thinking about housing with DWP, for example, and then lastly about who pays and how we, people's contribution to care. So because of the financial challenge of local government, and I'm sure you've got some evidence there, but I can give reference to what we think our overspends are from the ADAS perspective, if that's helpful. But what, in terms of those 4 lines of inquiry, the impact on local government finance is meaning that we can't invest in the models of care in the way that we would like. So we are, I suppose, very focused on an in-year result. So we can't invest into people's outcomes in year, because whatever we do has to have an in-year effect. So if I think about a model of care that needs reform, preparation for adulthood is a really good place to start. If we invest in younger adults to move into adulthood, or younger people to move into adulthood successfully, you need to make an investment in that service now for a financial return 4 or 5 years' time. If you don't invest, then you know that cost pressure will be into the future, but nonetheless you need the resources to be able to do that. Because council resources are so much focused on immediate mental health detention, adult safeguarding, supporting people with urgent packages of support, that's where the money is going in councils, and I'm sure David will refer to that as well. So we're not able to invest in those models of care. Then clearly we have financial constraints. So if we're thinking about how we reform our market and our care providers, that would also take investment. And we do that through fee strategies of local government, about provider relationships, about supporting joint workforce developments. It's the kind of activities that local government undertakes. In order to invest in provider fees, for them to reward their workforce, requires, again, investment. So most councils are currently negotiating fee strategies with their partners that are either at minimum amount of cost, slightly above cost, or below cost. It's really, really tight for councils at the moment. So therefore that means we can't develop the sorts of provision and quality of provision that we might want to see in councils. And then thinking about integration and relationships out there. So our partners are also really under financial challenge. If we think about pressures on the NHS, and I'm thinking about joint spaces, so where we discharge people, for instance, in mental health, learning disability, autism, from acute care, support people to avoid crisis through using things like joint funded packages of care, continuing health care. Those budgets between us are really, really tight and challenged, and because of that we spend a lot of time debating about who pays rather than on a conversation about, okay, in the longer term, how can we invest in people's outcomes to enable better health and wellbeing. And then lastly, because we haven't resolved the issues about who pays for care. So, what's the relationship between local and central funding of adult social care? What do we expect individuals to pay for their own care, either as a contribution or, as we know, some of the issues about the cap on the floor? That therefore means that we know that people are struggling to make their contributions to care, particularly for working age adults. We know there's a lot of poverty, and for older adults too, and carer stress. So that's some of the consequences of local government financial pressures, if that's helpful as a summary.
That's very helpful. Thank you, Melanie. David.
Thank you. So I think what we have to recognise is that adult social care is more or less half the budget of local authorities, and if you add it with children's, it's well over 70% of budgets, and therefore that leaves very little for the remaining services which many of your residents and many of my residents as well depend upon, including roads and libraries and things like that. So this is a lot of pressure on us. You also have to look at the amount of funding that's been taken out of local authorities over the last 15 years, which we estimated about £24 billion that we've made savings. So we have made a lot of savings to be able to meet the pressures, but we currently estimate that there is a funding gap for local authorities, the vast majority of which comes from social care. Next year of 1.9 billion, the year after of 4 billion, the year after of 6 billion, and the year after of 8.4 billion. And of course, over the course of the next 4 years, we estimate that there's a funding gap of over £20 billion into local government. Clearly, by taking out the cost from the cost base, we've been able to meet current demands, but we are reaching a point where it is becoming really, really difficult. If you add on to that the increase in a national minimum wage, the living wage, which we all fully support, but it does have an impact that it has to be paid for, and you add on to that the national insurance contribution, and I know that we've received about £500 million as compensation for that, but we think our costs are about £750 million on that. So that's adding further and further pressure on. So what's the impact of social care at the moment? It is really, really putting local government under a lot of pressure, which means that all the other services that we provide are becoming at risk. And most importantly, prevention. The amount of money that we spend on prevention is now falling. Was 8% last year, this year 7%, and that, I think, doesn't help for the future.
I think colleagues are going to pick up a bit further the issues around prevention and also other council services. Just finishing up on the council budget pressures, if you've got a sense of kind of any regional differences, any difference in the type of council. Is it kind of uniform pressure? Is it falling in certain parts of the country more so or less so? Is the ability to respond to these pressures greater in certain areas or not?
I think the problem is less about the authorities and more about the council tax base. So more and more funding is now expected through the council tax, as opposed to directly from local government, and therefore it heavily relies upon local authorities to increase their council tax. If you're operating on a low council tax base, then it does mean that there's additional pressure. So, for example, Somerset, if you raise it by 1%, you get £2 million. If you raise it by 1% in Hampshire, I'm sure it's more like 14 or 15 million pound. It is all about the council tax base, which has that impact. So, and the only other thing to say is that last year 15 local authorities applied for emergency funding support. This year I believe it's 34. So it is getting more difficult, and there's a wide range of authorities within that, including unitaries, counties and metropolitans.
Have you got a sense of how many of those applying for emergency support are driven by social care pressure?
I think most of them are driven by social care pressure.
And in terms of the finances, more broadly, kind of the next stage on, really, have you got a sense of how many are approaching Section 114 notices or considering that actively around because of social care pressures?
I can't give you an exact number, but certainly anecdotally the number is increasing, and the local authorities that talk about it seems to be increasing each year. I can speak for my own authority, which is Somerset, where we have declared an emergency financial crisis, and that is purely based upon social care pressures.
What impact does that have? Does the pressure, I suppose, to access emergency exceptional funding or take a Section 114 notice? What impact is that having on adult social care and the councils?
If you go for a 114, you lose control of the council. Somebody else comes in and runs it for you and makes all the difficult decisions, as I'm sure others around the table know. So Section 114 has got to be the last call. The impact of taking difficult decisions, though, means that you're putting pressure. Taking the emergency financial support is really just kicking the can down the road. You know, you've still got to resolve the fundamentals, and that's what we're not doing, resolving fundamentals.
Or passed on. You got a sense of how many councils are relying on their reserves to plug some of the gaps that Melanie and you touched upon, David?
I think the better question would be how many are not reliant upon the reserves, because I think the vast majority are.
I'll pass on.
Thank you very much, Paulette Hamilton.
Right, good morning all. I'll start by saying in local councils, I've worked in one for many years, they run over 136 local services, and 2/3 of that, as you so eloquently said, David, comes from children and adult social care. Many of these services are classed as non-statutory, which I've got to be honest used to drive me mad, and services such as libraries, museums, youth services that many of you know can take us a council over the edge with local people. So my first question, and it is to you and to David, is what are the trade-offs that councils, what are they having to make? What are the trade-offs that they're having to make between social care and other services? Can we start with you, please? Good morning.
Thank you. Yes, I mean, just to echo what my colleagues have said, the cost of adult social care is rising at a much higher rate than the stable funding sources that we have coming into council. So almost regardless of the ability to raise revenue through council tax or the precept at the end of it, it still isn't sufficient to meet the increased cost of adult social care. That's certainly happened in Bristol. Spending's outpaced local government funding, and so we have to make savings. Just numerically for Bristol, just as background, the overall proportion of the revenue budget committed in Bristol to adults and children's social care, which is what you were talking about, has increased by nearly 20% between 2017-18 and 23-24. From 56% of the total revenue spent to 75%. So the implications, the knock-ons from that to the kind of services that you're referring to, the non-statutory services, are quite profound, because there's so much, even with increased numbers of pounds in actual terms, in real terms the spending power decreases quite significantly.
So you, just to bring you back to the substantive point, your authority, I know, because I know it well, my mentor came from your authority. What exactly are you having to give up so you can carry on with adult and children's social care? What services are you having to reduce, are you having to let go of in an authority like yours that's been run exceptionally well?
So thank you. So within adult social...
Well, it's the truth, I know this.
Within adult social care and children's social care, we're having to emphasise, as Melanie said, you know, the survival within the year. We're having to emphasise the bare minimum of statutory services in order to be able to fulfil our duties under the Care Act. But then beyond that, any investment from the social services perspective in the excellent potential preventative work that can be done through communities, through the voluntary and community sector, and partnership work that we could do with the NHS is diminished. It either stops or it really slows down. That's the first point. And then the second point, and we see this in the deterioration of other public services and in the deterioration of the public space, is that areas like transport, adult learning, housing, education, environmental and green spaces, community cohesion, they're all areas that have had to take on board budget decreases as a product of the overall imperative to meet our basic statutory duties.
Thank you. And over to you, David. I know what we went through at the LGA, and even though we're on totally opposite sides of the scale, you worked really hard, and I thank you for all the work while we were at the LGA.
That's very kind.
But what are your thoughts? Oh, and can I declare an interest? Oh, yep. God. Yeah. I know David and Melanie really, really well. Fine. So I'll start with David.
That was apparent.
I was married to you, wasn't I, David? Anyway, go on.
What? We've strayed into too much information.
Coming out.
Over to you,
David.
Back to normal.
So I think the interesting part of that question is the statutory services, because I think we've got 700 statutory requirements upon us. But a lot of those statutory requirements are not clearly defined in law. So the library service is a statutory service, but what is a library service? And those are the debates that go on in county halls and city halls across the country. But there are lots of examples, I think, where money is having to be taken out of valuable services to be able to fund social care, because that's the only thing to do. So, for example, rights of way, which actually is really important, particularly in rural areas, rights of way, maintenance and registration and things like that, taken out of planning, taken out of community cohesion, various welfare and matters. But the other side of the coin is that councils are having to, we can only raise money in one of three ways. We can only raise it through council tax, we can raise it through business rates, which is quite difficult to influence year on year, and we can influence it through fees and charges. And what you're finding is that a lot of councils are now putting up their fees and charges quite dramatically, because that's only one of the few ways that we can to help to fund the other services. So there is a pincer movement on us at the moment.
So my follow-on question is around public perception. How are local councils really getting that across about the issue of using council tax, additional council tax and other revenue to actually bridge the gap? What's being done within local councils to actually ensure that this feeling that the public have, that services are absolutely dire and they're not in the place they need to be? What's being done in that space?
Will I go with this one?
If you go first, David, and then I'll go back to you.
That's fine. So I think that locally, each of the local authorities will approach it in different ways, the way that they communicate with their residents, whether it's through letters with the council tax increases or whatever. I think that there is a lack of understanding about social care amongst the public. So I think a recent survey showed that something like 28% of people believe that social care is fully funded through the NHS. And I've been to thousands of council meetings, parish council meetings. Very few members of the public talk to me about social care. What they do is they talk to me about potholes and they talk to me about waste collection and things like that. So for people, I think we've got a problem within the social care sector that our profile is not high enough, it's not talked about enough, and therefore people don't understand the true cost that it is. And we all need to do far more work there to change the perception of people. Social care is only important for most people when you need it.
So just before I move over to you, David, how much of the cost is being passed on through onto council tax of this extra funding, if you were to put a percentage? Or
Mel might be able to help me better there.
Right.
But by the time you add on things like the living wage, by the time you add on the national insurance, we're talking of several £1 million. But I'm sure Mel's got...
Mel, could you answer that bit of the question?
Yes, so ADAS modelled that only 25% of the cost pressure on councils by the living wage and the national insurance contribution was met by the increase in the social care grant. Wow. So the Department of Health and Social Care announced that the social care grant was being increased to meet the council pressures for the adult social care market, but like I said, we modelled it was about 25% of the cost. Now, that would be the total amount passed to councils, but bear in mind that the social care grant funds both adults and children's services, and locally it may well have been used in a whole range of ways in that scale of things. So there will be local variation. So for some councils it would be more or less than that because of how the social care grant is divided.
Thank you. And last but not by no means least, you.
Thank you. Can I note that in Bristol, as David said at the beginning, 1% of council tax increase in Bristol generally amounts to just over £2 million. So with the 4.99%, 2.99 and 2 for the precept, that gives us, something just shy of 10 or 11 million pounds. We have estimated by the same LGA reckoning as to the effect of employers' national insurance and the national minimum living wage increases for care providers at about 8%. The overall cost of that, we think that will cost Bristol care providers around £17 million. So even just in adult social care and just with the care provision elements of adult social care, regardless of children's or any of the other areas, the amount that's required for that particular issue is almost double what we would retrieve in the context of extra council tax. It's worth noting, we've done recent surveying and oh, sorry, there's a microphone. There's quite a poor public perception of government, local and otherwise, broadly, as I'm sure everybody knows. The Britain isn't working kind of perception, and I think in our context, there is support just over 50% for the increases of council tax that we proposed, but amongst the poorer sections of the community there certainly isn't support for it, and there's less support for the social care precept than there is for the mainstream council tax. And I think that's as a product of exactly the situation that David described, which is that for the majority of people who haven't got a learning disabled or physically disabled family member, for the 4 out of 5 people who never need to recourse to adult social care in their older years, social services isn't really a major factor in their lives, and so therefore potholes, bins, parks, things like that are more important to them. So it's a big argument, really, to win that social services should take more money from overall budgets.
Okay, that's a good place to stop. But thank you, all of you, and back to the chair.
Thank you very much. Jen Craft.
Thank you. I am mainly covering sort of prevention, but before we move on to that, I just wanted to follow up on your last sort of comment that you made. What kind of impact do you think that has on perceptions of people who use adult social care services? So if people are being asked to pay an increase either through a precept or an increase in council tax, have you got any reflections on how people then view people who use those services if they're not a user directly themselves?
I haven't really got a huge amount. I mean, I think that I can't really comment with any great knowledge on that. I do think that people that use services are very grateful for services, and when services work well, they work well for people. But are you talking about it in the context of people using all the resources and other people being resentful?
I'm just wondering, mainly around potentially disabled adults of working age.
Yeah.
If you're being asked to pay an extra amount in your council tax and you're not someone that is covered by adult social care and one of your family members isn't, is there a danger perhaps that increases perceptions of where the money's going?
I think that the marginal but meaningful lesser support for increasing the social care precept part of council tax in our recent consultation shows that there is that people aren't necessarily as supportive of social services as they are of other services.
It's just an interesting thing to follow on from the end of that, because I noticed in sort of pre-reading, I think it might have been you, David, that commented on the democratic deficit, 4% of people receiving large amount of the funding. Just that kind of, just wondering if that there is a perception from people on the ground. I pay X amount of council tax, but I'm not seeing the return in investment almost.
if I can, I don't think people make that jump. I think they know that they're paying more council tax and they're seeing less services, but they don't actually work out that that's because there's a sort of gap there. They haven't worked it out that's because social care costs are going up so much, and perhaps it comes back to Paulette's question about do we have more of a role to explain it to people, and probably that's right. But increasingly we are spending more of our funds on a smaller proportion of population. If you look at those that are drawing on the services.
Thank you. I'll move on to prevention. So there's obviously a really good argument. I think everyone in the room understands prevention is better than cure, and particularly in adult social care. How are your continuing funding pressures that all councils are under? How is that affecting your ability to invest in and deliver prevention services? And I'm particularly interested, my local authority is subject to a section, I can't remember which one it is, but 114 order. And they are restricted in terms of what they can provide that's not statutory. And there is obviously the temptation when you're under fairly strict financial limitations to pick at non-statutory services. How is that affecting your ability to deliver prevention, and what does that kind of look like in the short and medium term?
I'll give a bit of a national, and then maybe Hugh can do a local. So prevention is a duty under the Care Act. So as a statutory director, I do have a duty to prevent, reduce and delay adult social care need. And in the ADAS survey this year, only half of directors were confident they would meet that duty to any great degree, and most were confident that they weren't going to meet that prevention duty. And then the consequence of that, because I think I mentioned it in my intros, we have a very in-year focus. So it's all about managing the restrictions now, and in all honesty, trying to work with somebody in the way that minimises their draw upon adult social care and the cost. And as David said, we're also now seeing that we're spending more and more on individual people. So we're finding now, I think 20% of care is more costly than it was last year. So we've got this sort of effect of, though Nottinghamshire, we support 13,000 people, but there's a very small proportion who generate most of that spend, and it's not unusual for a package of support for either an adult or a child, particularly when leaving hospital for mental health, learning disability and autism, it's costing sort of £10,000-20,000 a week. So we have this, so the more cost of that we're facing, the less cost we're able to invest in prevent, reduce and delay. The sorts of services that come within that for Nottinghamshire would be things that I run in adult social care, things like reablement services, enablement, day opportunities. Those services rely on being able to support people to access libraries, parks, green spaces out there. So there's a direct link between the two. So not only are we not able to invest as much directly in those prevention services, and like I say, even those that have an immediate impact on need, we're also then less likely to be able to support someone to access those other facilities out there because of the financial constraint. The adult safeguarding has increased, so most councils are seeing 20% more referrals over the last 3 years for adult safeguarding. So that's a result of the quality of care we're seeing as one of those drivers of carer stress and of financial abuse. In times of financial challenge and cost of living, it's not unexpected, is it, that others, some people will take the opportunity to financially abuse somebody else. And we're also seeing an incredible increase in mental health detentions. Most councils are seeing about a 25% increase on activity over the last 3 years. So the more we're doing that kind of urgent, immediate work, the more we're spending our time doing urgent and immediate. And if you're in a council, as David said, most councils are financially challenged. As a leader, you're spending your time doing financial work, trying to manage in the budget, and as an operational leader, spending your time leading these urgent services. So as a consequence, we're kind of in this spiral of focusing on today and not able to think about, okay, what might be a really brilliant wellbeing service that supported older people with loneliness. That would be an example of a type of services that we're not able to invest in or develop at the moment.
How do you get out of it?
So I think there's a number of things. A multi-year financial settlement is one of the obvious ones, so that our Section 151 officers can think about a longer term view rather than just an in-year position. There's clearly the case for looking at how we pay and fund care and support, and what we think a good life should look like and how we support that, particularly thinking about older adults, because I do think older adults get a slightly better deal from adult social care than working age adults actually. And I think the obvious point would be about resolving local government finance, but that's quite a bit of a wish at the moment, isn't it? But that would be the obvious thing to me, would be thinking about what's a fair funding settlement for local government.
Thank you. And I think just before we move on, just what kind of benefits are sort of local authorities failing to deliver for people who receive adult social care, because you're not able to invest in prevention services as much as you would like?
What sort of benefits are
local authorities failing to deliver for people who are in the adult social care system due to not being able to invest in prevention services?
The main benefit and the most kind of desirable is all of the benefits that one gets from the fabric of a healthy society, from supportive communities, building on community, asset-based community development, building on community assets in order to support people to enjoy and benefit from and gain good health from their community context. I mean, we do quite a lot through public health in Bristol. Investment, we've got a community impact fund which is fiercely protected, and we invest in longer-term community investments. But the problem with the adult social care end of things is the short-term nature of funding sources, one-year funding precluding proper investment. So what we've got a good thing with Age UK, leading a community consortium of our community anchors, Wellspring, BS3, the South Mead Development Trust and Knoll West Community Health Park, through the Discharge Grant and Better Care Fund, but it's always year on year. So you never know towards the end of the year you're in as to whether you're going to be able to continue it. But that work we've got in our transfer of care hubs, so that when people are coming out of hospital, they can be diverted to a community solution. And we've got now at our front door of our adult social care, so that people can speak to a representative from Age UK right at the outset. But it's not enough, and we can't do sufficient to really develop that community capacity that's going to be properly beneficial for people.
I think one good example would be that for an older adult, we would be really focused on just providing the minimal amount of support in their homes. It may be that, I don't know, they may take a direct payment, and we will be looking at what is the minimum they would require to stay relatively well. What we wouldn't be able to invest in is necessarily having friendships, being able to get out and about more. So kind of what somebody's receiving probably is the basic personal care, the bare minimum, rather than what would be needed for an older adult to really enjoy a great quality of life as they age. So that's kind of where there's a sort of a rationing over time, if you like, because of focusing on the most immediate need.
Can I just come back to the prevention, because I think prevention is one of the ways out of this, and I think we all know it, but it's finding the way, how to implement it. So I said before, councils this year, last year, was spending 7% on prevention, whereas the year before it was 8.2%. It's a falling amount. But in the LGA, we think there's 6 things that could be done which would help to advance prevention. I mean, some of them are funding linked, I've got to say, but there's got to be a recognition of the pathfinders that are working on prevention, and we've got a whole host of local authorities that we can mention that are doing that. So it's taking that work and scaling it up to ensure that there is some prevention work, making sure that we work with partners to enable taking down some of the barriers, that we can work with our partners to ensure that prevention work's delivered, and in line with that, there were some really good recommendations in the Hewitt review about prevention, which we think needs to be picked up and taken forward. We also think that the way that social housing, supported housing is funded needs a review, and that would help us to work on prevention to keep people independent for longer. And then the other one is the workforce strategy. If we had the right workforce strategy with the right skills, then we could spend a lot more on prevention. I would say that prevention is something we all talk about, but it gets less and less attention and less funding. And I would say, the suicide prevention fund, which was withdrawn from local authorities last year, was doing some great work, and now we're in a very exposed area. So prevention is great, but it does need funding.
Thank you. Back to you, Chair.
Thank you. Greg Stafford.
Thank you very much, and apologies for being late, Madam Chairman. My question is going to be around the Better Care Fund. So ADAS have said previously that the sort of political direction led to the Better Care Fund being prioritised to ease pressures on the NHS, especially on discharge. Do you think the recent reforms to the Better Care Fund will effectively address the issues that it's trying to solve and shift the focus back towards the prevention end? Whoever wants to go first.
I can have a start there, certainly. Yes, I think in theory, I think a lot of councils' Better Care Funds, I've worked with a few, as they are a stratified layers of activity that have been put in over the years. A lot of the funding that is within Better Care Fund is actually established long-term based budget orientated funding for councils and for other organisations, so there isn't necessarily the flexibility within there to do huge amounts with the majority of it. But what I will say is that it's refreshing to hear in the context of the potential for developing around the 3 shifts, the community prevention and digital, and in the context of developing neighbourhood teams, it's refreshing to see that the consolidation of discharge fund and other such things into the Better Care Fund as flexible funding might be useful in order to create some community capacity that would help us to alleviate pressure on the acute sector. There's some excellent work going on through the LGA. I'm involved, I know a number of us are, in regard to the future of prevention, communities of practice around the future of prevention, that's looking at reablement services and looking at how they can be developed to be a much more coherent community offer that actually has as its central focus keeping people out of hospitals and keeping them safe at home, because accident and emergency is not the place to go if carer breakdown is your issue. What I will say, and I would like to get this point in, is that some anachronistic financial mechanisms such as continuing healthcare, which I know the DHSC is looking at the moment, and Section 117 aftercare, they have no place in these new community ideas. Neighbourhood focused community teams is integrated locality teams, as we call them. We've been working on them for quite a while. I've been working on integrated care for 25 years, let's face it. But so the lack of reform obviously is demonstrated through the lack of progress that we've probably made.
We're coming back to this point
in that, yeah. But in regard to continuing healthcare, it would make the world a much better place, and we'd be able to collaborate and do a lot more if we could avoid having difficult conversations about money all the time.
Mm-hmm. Thank you.
Yeah, the Better Care Fund was set up some time ago now, probably 10 years ago. I remember it was my job at the time to be setting it up, and we had a real spirit, because it was Sir David Nicholson. It was about getting upstream. Then in 2015, 16 and 17, there was dramatic reductions to local government budgets, and the BCF was largely deliberately repurposed nationally to protect adult social care. The elements that have come in since are predominantly around hospital discharge, and I have to say that locally and nationally that's been used really well to increase social care capacity for supporting hospital discharge, particularly around home care reablement type services, and services like the Red Cross, who go in and help somebody for 72 hours that doesn't need ongoing social care support. So I think those services are really important, both the base budget care packages and those. I see very little slack, therefore, to reinvest that into neighbourhood health. But I think neighbourhood health is absolutely where we need to go. But I don't think the BCF has got any particular flexibility or scope in it to be able to make that shift. Neighbourhood health, I think I would agree with Hugh, and intermediate care is really where we should be focusing on in our relationship with the NHS, of working around primary care, supporting people both to avoid needing crisis support. So I think that's where social care is best placed, is supporting people in a crisis, supporting their family to cope where possible. And intermediate care isn't just for older people, it's also for it can be support for somebody with mental health issues avoiding hospital, for somebody with learning disability and autism who may be at risk of needing admission to an assessment treatment unit where we know the outcomes are really poor. So investing in that community capacity is certainly the right policy direction. I just doubt, as ADAS does, that there's a flex in the BCF to be able to make that important investment shift.
Thank you. But just before I come to Councillor Fothergill, so can I just be clear, what you're saying is that the sort of the rhetoric from the government is actually not matching up with the reality on the ground, i.e. the Better Care Fund will not make any difference to the kind of the front-end prevention. Is that what you're saying?
Most local areas have reviewed the BCF annually, so I think there's a perception that local areas don't review it and know what's in it, but I would guess, as Hugh, I've been in other places, I've been in Nottinghamshire for a while, but I've been in other resources, other places do, and we do review the resources in the BCF very actively to look at investment, and it underpins community health services, reablement services, social care services, so that's where the money is going. There isn't necessarily a lot of free unallocated resource to invest, because as Hugh's described and I have, the discharge element of the funding is already invested again in home first type services.
Can I just note that I think the Age UK initiative that we were talking about is a commitment of less than 0.5% of the total of the Bristol BCF. So it really is not major.
Thank you. Councillor Fothergill.
I defer to my colleagues. I think that they've got a far better understanding of BCF, and I think they've given you a full answer.
Okay, well then if I move on then, back to you to start with, Councillor Fothergill. Obviously the Better Care Fund is a pool resource and it's intended to encourage integrated working between the NHS and local authorities. What else, sort of within that context, needs to happen to ensure more integrated working between sort of at system level to reduce the adult social care pressures? I know that's a huge topic, but within the kind of the stuff we've been talking about, discharge, sort of the discharge end and the prevention end, what else needs to be done?
So our view is that the integrated care boards, certainly where they work well, work very, very well, and there is some good sharing of resources and some good sharing of finances. There are examples across the country where they are not working so well, and it's a bit of a tapestry. And I think that there needs to be more review of that. I think the review of them by the Hugh review again needs to be picked up, and we need to come back to it to say how could we improve. Absolutely, councils, local authorities and the NHS need to be working very close together, but there is one very big difference, which is that the NHS can keep overspending and local councils can't overspend in the year. We've always got to come in balanced, so for local authorities there will always be a pressure on achieving their budget.
Yep, so leadership at place is absolutely essential, as David said, and so the ability of that leadership within the integrated care board and integrated care system to really focus on neighbourhood health and prevention, but equally there's a reality about the pressure that our colleagues in the NHS are under. But there's some really good examples where all parts of the place are involved in that. The prevention fund, and David's mentioned the Hewitt review, was a really useful model, but again there's it's not a mandatory fund, so there's an option, isn't there, for areas to disinvest that elsewhere in financial pressures, particularly when they're under national scrutiny for their financial control. As I think Hugh's referenced, the interface areas, not just in terms of where we deliver services together, there's a huge amount of emphasis put on hospital discharge, which is disproportionate to the amount of people that benefit from that compared to those that need us to work in an integrated way. But those services such as intermediate care, the relationship with community health services, and then the way that's funded through Section 117 and CHC, they're outdated and they cause dispute and conflict locally. So that will be the areas where there's rightful reform and change.
I just had, to reiterate the point, the BCF has potential to be a developmental funding mechanism, but the other funding mechanisms through which NHS and local authority partnerships are organised, which are continuing healthcare and Section 117 aftercare, preclude good partnership arrangements. They prevent good development of joint systems. And so it's almost like you've got a situation where you're encouraged to develop in BNSSG, Bristol, North Somerset, South Gloucestershire, it's an excellent partnership. We work really well together, and the 3 chief executives of the 3 councils are all sitting on the Integrated Care Board, which is quite unusual and a very positive thing that we're proud of. But at the same time, perennial issues around other joint funding mechanisms always thwart our best intentions for proper system partnership. So reform of all of the funding around health and care would be beneficial in order that we could do that more effectively. Well, some people talk about it in the context of a national care service, but some mechanism through which the development of budget pools that were broader than just around acute sector pressures in urgent and emergency care, but pool budgets that were around pressures in the context of long-staying people in mental health hospitals, for example, or pressures when it comes to supporting younger adults, the increasing incidence of younger adults with high-level needs who have to recourse to very expensive care packages that we should be paying for jointly. At the moment, the system is organised around local solutions. So at the end of it, you've got some basic guidance, but you have to make local solutions. Local solutions equals debate and potential stasis when it comes to financial matters.
Thank you.
I mean, I don't think we've got time to go into that in any more detail, but I think with your permission, Chair, I think any views on that we welcome in writing, I think, because I think that's a really important issue. Thank you very much.
Josh Fenton-Glynn.
Thank you. I too am a recovering Cabinet member for social care. So we've seen the budget spent on working age adults increase by 1/3 since 2020. Could you perhaps give us an idea of what's driving that?
I think the good news is that people living with a disability are living longer. I think the downside for them and for local authorities is that living longer is with more complex needs as people get older and into maturity more, and therefore those complex needs therefore are driving additional costs within the social care sector.
So just to drill down on that, I mean a 1/3 increase in 4 years. I mean. In my old authority, it's about 50% of the spend, and it's getting close to that in most places. That can't just be people living longer. Is there something else that's driving that cost?
Mel might be able to give us some insight into that.
Yeah, so there was a County Council Network report published on this last autumn, which actually, it wasn't just about county councils, they used national data. So that clearly identifies some of those drivers of costs. Oh, yeah. It's a really brilliant report. Certainly both that report and experience of ADAS and locally, there's a group of people that we support that are sort of titled nationally Transforming Care, Building the Right Support. So this is a group, it's a very low number of people, predominantly with learning disability and autism, but also an element of mental health, who are either avoiding admission to or, importantly, stepping down from NHS long-stay hospitals, often high or medium secure. So we typically have spent a lot of time in segregation, isolation, and with complex forensic backgrounds. And that's a group of adults that is increasing in number, particularly as people are now being recognised in justice system as having disability, so that there's a trend actually of where we're managing to support people to avoid admission, but people are transferring over from prison into that group. And they're a very costly group to support safely in a community setting, and that can cost us £10,000-20,000 a week. As Hugh said, we jointly support that group, but that's one of the drivers. There's also another group of young people transitioning from the SEND system, often with a mental health admission. So this is maybe where somebody's been living quite successfully with adults and managing through school for a while. So adult social care won't have particularly been aware. They'll then be admitted through the health system. Still maybe we're not working together, but then the situation will rapidly escalate. The person will require a very intensive package of support. So when they come back either to children's or adult services, again, it's a very costly package of care. So that's another driver of the cost. And then the other element we're seeing is about providers managing risk. So David's touched on the workforce strategy that we need. We know the quality of care is really variable around the country. Providers are struggling to recruit and train people, and working in some of these settings is actually really, really challenging. I mean, I used to love it, but for some people it's really difficult. You need really good training, you need good support, and you need to be able to pay. And so some of that is increasing the provider's cost as well.
Just to pull that apart, I'm aware from my experience that it's more expensive for a working age adult placement usually than an older person's placement. But you're saying that specific cost is going up kind of exponentially as well because we can't recruit into those roles. Is that correct?
It's partly the recruitment, but also it touches on some of the feedback that David gave, that we're supporting people now to live nearer to home that 10 years ago would have been in an NHS institution or hospital. So we're also supporting people, which is brilliant news. That's what we want as a society. But we ought to recognise that doing those bespoke packages of support for people that require specific accommodation to be repurposed or built, a specific care team recruited, is really intensive and costly work. So you've got both of those factors.
Domiciliary care in this instance is more expensive than residential care?
Yes.
Okay. So moving on, in my drafted question I said a report by the County Council's network says, because I had read it before in preparation, but one thing that it does make clear is that actually there's a bit of a gap where people are falling through some of the holes when they leave, and you mentioned this earlier actually in terms of what we're not paying for in prevention. As people leave the children's social care system, they're not being picked up by the adult social care system. Why are they falling through, and what can be done to do a better job on that?
So I think where a younger person has got a lifelong disability and are well known by councils, in the main, that movement through life is supported quite well. So adults and children's social care work together, but children's social care aren't involved in every young person that has a disability, particularly neurodiversity. So there will be occasions where somebody is working really well in the special educational needs system, attending school, and then there's that. But so they're not, the risk of them needing adult social care isn't quite identified in that way. And the school may be thinking, okay, they're going to transition to university or college quite successfully. But as a family is supporting a 17, 18-year-old, the needs are quite different. It's at that point sometimes that families will fall into crisis and challenge. And supporting that is where people will fall through the net often, because trying to work out whether someone will need adult social care in those circumstances is a bit of a guess. But the council, as a sort of social care team, children's of adults, would not be working with that family necessarily. I don't know, Hugh, about what you see in Bristol.
I think what I'd like to draw attention to is, especially for some of the core, for cities and the core cities, is the relatively young population, Bristol. And when you're talking about care leavers or people who, one way or the other, might have experienced quite significant trauma in their childhoods or in their backgrounds, whilst those people they may have received children's social care in one way or the other, but they're not children with disabilities, or maybe not people that would recourse immediately as they become 18 to adult social services, but they may very much struggle in adult life and be much more prone to the kind of disadvantages or multiple disadvantages that can result in drug and alcohol use, for example, homelessness, involvement in the criminal justice system one way or the other, and people who are generally at risk of lifestyles that are less than organised and less stable. And somewhere down the line, some of those people do recourse back to adult social care services. And when they do, especially when there are issues around people challenging services, etc., some of those services can be really quite costly. Now, in the past, there were things like the Supporting People programme and the Independent Living Fund and things like that were geared up specifically to support people with those within those kinds of circumstances. But again, it's one of those things where in an ideal world we could be much more trauma informed, we could be much more capable of supporting people who are having difficulties in life early on to prevent them recoursing to these complex complex packages of services that are not very well coordinated and probably quite costly.
Yes, we don't have an adult early support offer through transitional safeguarding often, and that's one of the areas, if we think about prevention, I think would be really key to be thinking about how we would invest in that more collectively.
Just a flashback to a unsuccessful campaign I ran to save the Independent Living Fund. So, moving on, the purpose of this inquiry is about the cost of inaction. You've hinted at it there, but I wonder if you could just make a bit clear for us what the cost of inaction is in cases like this, where people are falling through the gaps and not getting that continued support, and therefore they're more likely to either end up, in taking part in harmful behaviours, as Hugh just outlined, or simply just needing a greater deal of support rather than being transitioned and supported into meaningful activity, be that work or otherwise. I wonder if you could talk about what the cost of inaction, both in terms of the greater need, then in terms of their parent carers and so forth, ending up needing more services themselves, and then finally the cost of them not working and not being supported to have kind of meaningful activity.
Happy to have a go. So I think what you've just described is another way of saying prevention. It's about getting in there early and doing the work that needs to be done, and the cost of not doing that is that the cost escalates later. So that I think the cost of inaction is not only for the individuals who are living with a situation or a condition that will become more complex, but I think there is a cost to the councils, the local authorities of not taking that action earlier, because that leads to the financial pressures that we've talked about. There is a cost on the workforce because it means that we require more skilled workforce and we don't have the workforce strategy that we need, and we also clearly need additional employees coming into that role. And then I think that there's a cost on just society generally, that we are seeing more complex cases which are not being resolved earlier, and therefore are leading to greater strains on the councils.
Do we have any numbers that goes with those buckets?
Not
you
sure.
can write to us if you want, but we're
Right,
really keen on the numbers as much as we are the buckets.
Yes.
and what it falls into. Thank you.
Thank you.
Oh, thank you very much. Quick fire, last question to this panel from Ben Cole.
Yeah, just a quick one, sorry. You talked about the need for multi-year settlements, and the government set out in the Local Government Finance Policy Statement 25-26 its intention to move to multi-year settlements from 26-27. How helpful do you think this will be?
I can answer that. I think it's incredibly
Very
helpful.
helpful.
We've called for it for years, for the last decade probably, and we welcome it. It gives us visibility. We commission services not on a year-by-year basis. We commission services on a several-year basis, and it just gives us that visibility and that security to be able to maximise the pound that we're being given. So, very welcome.
How important is it that the same thing happens in the NHS, the lack of it in the NHS? Will that inhibit you making the full use of the multi-year settlements for local government?
Yes, I mean, I just said things like the Better Care Fund, because often the planning guidance for that comes out after, very late, for anybody who's chaired a health and wellbeing board could give evidence of that. So it's really important that those are aligned, so, alongside that, or else there's a disincentive to those points of integration. So yes, most definitely, we need to think about how those planning cycles align. They don't at the moment. The NHS planning cycle is different to local government planning cycle.
Thank you very much. So that brings us to the end of panel number 1. Thank you very much. Hugh, Melanie and David, thank you so much for your evidence. Let's switch over. We won't be suspending the live feed, so we are still live. Let's do it as fast as we can possibly do it. Thank you. Two, thank you so much for being with us. So just like with panel number one, if you wouldn't mind saying who you are, what you do, and thank you for being with us. Perhaps starting with Anu.
Thank you. So I'm Anu Singh, and I am privileged to be with my NHS colleagues, but I chair what has already been trailed, an ICB, an Integrated Care Board, which obviously is much more than just the NHS. It's local government, it's working with communities, it's working really closely at place. So I'm the chair of the Black Country ICB and also work with a number of other ICBs.
Thank you so much.
Hello, I'm Birju Bartoli. I'm the Chief Exec of Northumbria Healthcare Trust, which is an acute and community integrated provider trust in the North East.
With us.
And I'm Isabel. I'm the Director of Policy and Strategy at NHS Providers. We represent all NHS trusts and foundation trusts in England. That covers services ranging from acute, community, mental health and ambulance as well.
Thank you. We'll start with Andrew George, please.
Well, thank you, and nice to meet you all. The County Councils Network and the NHS Confederation both have produced reports and commentary about delayed discharges from hospital, and have found that the vast majority of delayed discharges in fact are indeed unnecessary admissions in the first place. So, I mean, if you speak to clinicians who are admitting, particularly those coming through the emergency departments into hospitals, they will say that you can only know for sure that a patient was admitted inappropriately in retrospect. Therefore, the question really is, are those reports, the NHS Confederation and the County Councils Network, just being wise in retrospect? And are the clinicians right that actually you need to take a precautionary approach, or are they just being overly risk averse? I don't know who would be best to...
I can take that.
Okay, yes, thank you.
Yeah, so I can obviously talk from the perspective of Northumbria Healthcare Trust. I think that we've been fortunate to have a number of different routes that have evolved to prevent an admission where we can. So almost admission to a hospital bed is of the last resort. So either we turn people around as much as we can from the emergency department or through our ambulatory care, same-day emergency care unit, which is a unit that tries to put some very senior clinicians up front to take those risks that you allude to, rather than leaving it to a more junior workforce. I would say in our experience we have a small number of people relative to the number of admissions that we have that are come under the banner of a social sort rather than being acutely unwell. The majority, I would say, for my organisation are those that need to be in hospital. We are, because of the nature of our model of care, whereby we have very senior clinicians up front in the patient's journey, that delivery of risk is far less than perhaps there may be in other models of care.
And is that, yes, Isabel?
Yeah, so I think both sort of we're thinking about delayed discharges, but also avoidable admissions, both of them complex issues with multiple factors going on. But I think we know that there is a link between what we'd like to see, a more stable funded social care system, and being able to get people the right care in the right place at the right time. And that principle of right care, right place, right time is being is difficult to achieve in all cases at the moment. So I think that's where we see that really clear link with showing up in terms of delayed discharges at the back door of the hospital, but also avoidable admissions at the start. And I can go into a bit more.
We're going to come back to avoidable admissions
I'll
specifically later.
So yes, I just wanted to kind of get some clarity. I mean, obviously, no one's arguing for the wrong place and the wrong time. So I don't quite. I mean, I'd be interested to know whether there's any kind of substance to that rather kind of platitudinous statement, if you don't mind.
Well, I think it's about so we're seeing a barrier, social care inaction as a barrier to being able to achieve that at the moment. So, so that's the link I'd make. Sorry.
Yes, sorry.
May I respond to that? I mean, I think what we've outlined, and certainly what we picked up in the previous panel, is at the moment we are all players in a system that is forced to be managing risk rather than actually helping people to be where they need to be. And part of the driver of that is because the system and how people navigate through the system is underfunded at every single point of that system. So in order to be safe, because these are some of our most vulnerable people, we have to take decisions that prioritise safety. So if you just think of any part of our system, you look at general practice, lists have grown by over 20% in the last decade. You think about what my colleagues have been talking around same-day emergency care. People are coming into A&E, they're coming into a place where they feel safe, and we are trying through transformation to make sure that we don't admit them unnecessarily, but sometimes we absolutely have to just make sure people are safe. And transformation is in place, but it's still limited, and it can't actually deal with the volume of underfunding across all points of the system.
No, well, I was just trying to get to the bottom of whether you felt that the claims that the majority in some cases of these reports of admissions to hospital through the emergency departments were unnecessary or avoidable. I mean, one can understand that there's a strong case for a strong emphasis on preventing those episodes happening in the first place. But when it comes to making that clinical decision about an admission, I think what you're saying is that those claims that there are unnecessary admissions is being exaggerated.
Yeah, I think that if you have senior clinicians as early making the decisions, they're less likely to be avoidable admissions. I think that if you have a more junior workforce, arguably they're going to become more risk averse, and so you're more likely to get avoidable admissions. I think there is something about, if we flip the question slightly and say avoidable attendances to the emergency department, I think the nature of what my colleague here has said in terms of pressure in primary care, pressure on the elective pathway, both of those can impact in terms of, because people, for example, are not getting their operation as quickly as they might need to, are now turning that, what would be a planned procedure, into an emergency presentation. Or similarly, because of the pressure that primary care is under, because they can't get to see their GP, they may turn up at the emergency department instead.
Okay. Can I turn then back to the other end of the scale as well, the discharge process? It seems, I mean, certainly from my own local authority in Cornwall, the indications are from the statistics that we can interrogate suggest that around a quarter of all discharges are delayed as a result of not being able to identify sufficient social care package, and the remainder either have a primary health need which needs to be met by in the community or elsewhere, or it's a combination of the two. I mean, is that something which you in your different perspectives find is the same? It's just that there's a kind of current conventional wisdom that is entirely down to social care, but in fact actually is more complex than that. Is that a fair point?
Me to kick off with the national perspective. So I think, if we're thinking about delayed discharges, we're automatically thinking about the issue of patient flow across the whole system and all the different parts working together so people can get to the right place where they need to be. And if you've got one bit of that not working well, then it causes challenges, which is what we're seeing in terms of the social care element.
Have you ever quantified it? Because that's what we're really interested in, is those numbers.
There's some.
Well, there will be local, as you've talked about, Andrew, local understanding about what's happening locally. I think I don't have a breakdown.
Anna has a number. Do you have a number?
Well, let me go to my hospital colleague, and then I'll do my system number.
So from an organised trust point of view, I need to put this in the context of I have As an organisation, we've spent a long time working collectively with I've got two councils, chief execs, to build really strong relationships. So I would say I'm at an end of the spectrum whereby we have delayed discharges, but they are relatively smaller than perhaps what might be found elsewhere. Mm-hmm. So the numbers based on that for the calendar year of 2024, there were just short or just over 2,500 bed days. Sorry, 25,000 bed days, of which that cost equates to the hospital of 8.9 million. I can send the breakdown of that to you separately afterwards. Mm-hmm. And you can then see the impact that would have on what my colleague Isabel has said in terms of patient flow as a consequence, because when you equate that up into roughly, that was bed days, if you equate that down to patient numbers, the impact on actual ward numbers, that impact on flow can be seen.
The 25,000 bed days, that is not just those who are in beds waiting to be discharged. Is that the total number through the entire system of people who are waiting unnecessarily across the whole of the flow of the hospital, or is that just the end number?
That is when they are medically fit for discharge.
Right, that's just the end number.
Go. Yeah.
So you've not done the quantifying of all the other delays that happen in the hospital for all the other wards that are affected.
Yeah,
you don't have that.
That's just everybody that is they're now medically fit for discharge, and they're now it's the time that they wait before they are then discharged.
So when they're in that position of no criteria to reside, when they're in that criteria, I suppose it depends whether you have the statistics on the basis of the pathway analysis, or whether you have where the budget flow needs to be found. In other words, whether it's a social care budget or whether it's primarily a primary care need, either for continuing care or for other health care.
That will be a mixture of.
Yes, exactly. Is what that mixture is. I'm just trying to kind of get an indication from a more global figure. I'm sure that Cornwall is reflective, probably, of the world as a whole, the country as a whole. But I mean, is that fair, or is that kind of reflected in your own areas? The 25.
So I think if I sort of think about January 2025 this year as a snapshot, just to help give a bit of context, we had an average of around 23,000 patients on a typical day not being discharged. That, if you're looking at the difference between acute and community settings, acute settings, that's nearly 3 in 5 patients at the end of a typical day not being able to be discharged when they are medically ready to be discharged, and that was at a nearly a 2-year high in January. So we know this is a problem, and it's getting worse. And if you look at the community equivalent, then that's 4 in 5 patients at the end of a day. So, and that's been at that level for about 2 years. So we've seen that as a trend, and that's a worry. In terms of as Birju said, there'll be complex reasons then for what the reasons behind that. So we know social care is one part of it, but we know there are things within hospitals as well. So in terms of discharge processes, etc., that are important.
You know, how much is it part of it?
And I will write to you on that if that's possible, because I think NHS England have done a breakdown, but I don't know how. I'd want to get the most recent figure for you, if that's okay.
Yeah, the last one we see is 2023. So.
Yeah, I think that's the last one I've got actually. So I probably don't have an up-to-date figure on that beyond that.
We've got some more kind of topical regional data, but I just wanted to, before I share that, just emphasise the context a little bit. Building on our colleagues in the first panel, it can actually be unhelpful to have social care looked at as an alleviation for delayed discharges, because that forces us all to have very tactical crisis-based conversations. And actually, whilst it is incredibly helpful to look at those pathway problems and those discharge problems, because those are problems that we as systems are looking at, because we know pooled budgets, bringing teams together can help to solve that. If that's all we're looking at in terms of our partnerships, then we are just going backwards. There is something about not talking about social care as a solution to discharge. Having said that, I will share a little bit of what we've found, but hopefully in a really positive way, because I'm really hopeful about this review. Actually, I think this could dramatically change the stagnation that we've been suffering for decades now. Given
when you say the review, you mean the Lacey review?
Yeah. Because what we are finding ourselves in the NHS, really gripping the 3 shifts. It's where local authorities have been for a long time, embracing prevention, looking at neighbourhood health. This could be really monumental if we help local government to actually throw off some of those the shackles and the underfunding. So the thing about discharge is that it can work really well if you have integrated teams working really well together at place. And you can't have that if local government haven't got the headspace or the staff to put into those integrated discharge teams. So in the Black Country, we've got 4 really, really good councils, amazing, again, you know, part of the Integrated Care Board, part of the Integrated Care Partnership. And if I take one of them, Walsall, for many years we've been looking at how we can repurpose the BCF, target it at those medically fit, and the data that we've been tracking since 2020, when we first started to do that, by putting a single budget together, putting a single team together, targeting at discharge, we've moved from above average to well below average and kept that on trajectory for the last 4 years. So that's data we can certainly send you. What we also have is where we probably have got less mature partnerships, we can look at delayed discharges and attribute them to delays in perhaps finding social care solutions. So across our other 3 places, we've looked at perhaps data that shows us about 11,000 delays attributable to social care. So not the total delays that Birju was talking about, but these are the ones that we've been able to look at more scientifically, which equates to 31 permanent beds being taken out at the cost of 7 million. Mm-hmm. So
what proportion though of delayed discharges is that?
I don't have that data, but it'll be similar to what Birju's talking about. That there's a much larger percentage, and then you're able to look into the smaller figures.
Just finally, if I may, I mean, I think the point about integration, I think that Councillor Fothergill suggested that there's a kind of a tapestry of success and failure, if you like, across the country as a whole. I don't know whether that kind of is reflected in what you're saying in terms of how integrated that kind of process has effectively been. It sounds very good in Black Country, but with regard to the pressure within hospital beds, I remember that the NHS Confederation produced, in my view, an infamous report in about 20 years ago called Why We Need Fewer Hospital Beds. And with bed occupancy rates in the high 90s, I mean, surely, I suppose this is a question to Birju, is surely we should be working towards the mid 80% bed occupancy to avoid the kind of pressures and the crisis kind of management and the dysfunctionality of the admission and particularly discharge process.
Yeah. So I think you're right. We're at our optimum when we're in that 85. We can afford to go up to kind of 90%. Anything over that, and you really start to feel that flow pressure. Some of that bed-based number, to be mindful, and again this will depend on individual models, will incorporate elective beds, so beds for planned operations. So as an organisation, our planned bed base for those planned operations is really very small, because clinically things have evolved, and we can do things much quicker now than we used to with day case operations, for example. We've done some modelling internally that says if you do a do-nothing scenario, both clinically, so from an NHS model point of view, as well as delayed, and using ONS figures, by 2040 we would need an additional, so our organisation would need an additional 242 beds. Wow. To me, that would strongly...
What proportion is that?
So that is the equivalent. I have one hospital currently, which is a specialist emergency care hospital. It's another one of those that I would have to build.
How much does that cost?
So we built that 10 years ago, and that was about 100 million, or just so it's from a capital point of view, it's not affordable. From a workforce point of view, revenue, it's not affordable, and the people don't exist.
No, I'm interested in this because the do-nothing scenario is exactly what this inquiry is about.
So the do-nothing, this is the do-nothing scenario. And whilst that isn't all about social care and delayed discharges, that is about how we change that clinical model, which I think...
Sorry, the 240, what proportion increase is that on top of what you already have? That's what I'm trying... I don't... 240 means nothing unless...
It's about a quarter of my bed base.
Okay,
again,
that's fine.
Now.
Yeah, that's right, thank you. Yeah, sort of 25% increase in 10 years.
Again, and that is on an organisation, I would say, that uses our beds pretty efficiently. I think there is a drive, and as well the context, again, from my area of the world, the number of people over the age of 75 is increasing quite dramatically. So the growth in population for me is over the age of 75 and over the age of 85. So that will have an impact on social care in the northeast.
Right. Thank you very much.
Yeah, did you want to?
Yeah, I was going to build on that. I absolutely agree. And one of the challenges we're facing across the NHS, working in partnership with communities and local government, is actually how do you prevent that happening? So actually, how do we not wander into the do-nothing scenario? Yeah. So we already have some good direction of travel around that, which is about neighbourhoods.
The operational guidance says that you have to, right? So, yeah.
Yeah, so moving into prevention through different ways of supporting and preventing escalation of need. And the thing that is most important, I guess, again, not in terms of direct social care, but we heard it from our previous panel, the thing that will make the NHS enter into those tough choices is growing acuity. So escalation of need. So it isn't just the demographics, it's that people are getting iller and frailer because we just heard from local government, we aren't able to prioritise things like voluntary and community sector investment, who would be able to support our population. So by the time the demography will hit us all, actually they are less frail than they need to be. They have less options than they need to have. So we're almost wandering into a scenario where we are having to build those fifth lanes on the motorway, because at the root cause of it all, perhaps where we should be addressing those wider determinants of health, local authorities aren't able to because they are forced into crisis management through targeting.
We're now very definitely straying into my
Sorry.
questions. No, which is fantastic and predicted, because we focused a bit on the hospital side of it, and now we really want to drill down on the community bit and the integration between the two. So to carry on, Arnie, with you, you've set out what the challenge is, but how do we now deepen those partnerships? What do we need to do specifically, differently?
I guess we're incentivised, aren't we? You heard from the previous panel, and we're incentivised to think your bit of the world, not system. Now, there's been a lot of rhetoric around thinking system, and integrated care boards, and many partnerships through decades previously have encouraged us to think system, but none of the incentives have flowed that way.
What would be a good example of an incentive that would work to get people to think
funding?
that way?
So if funding was joined up across different government departments and we were able to take a multi-year prevention-based lens, that's number one.
When you say that, what we're talking about there is a pot that's shared, and you're all equally responsible for it. Is that what we're saying?
Exactly that. So in layman's terms, we heard about the delays that can happen and tense partnerships that can be developed through CHC conversations, 117 conversations. What we absolutely know works are pooled budgets at place. So pooled budgets at place where we know that communities, voluntary community sector, our health partners in those community services absolutely understand what matters to their communities, Not what is the matter with them, what matters to them to keep them well. So you are able to spread the jam much thicker, rather than our end of the world where we're having to spread it so thinly because we are not addressing the escalation of need. So that is number one. We just aren't encouraged to think in that way by our regulators, by the performance stats that we are reporting, by personal accountability that everybody...
So there's a lot of talk about the regulators currently, obviously. So what could the regulators do differently to encourage this kind of thinking? You mentioned regulators.
I mean, I defer to my CEO colleague who will, I know, be in daily conversations about metrics that are all about today.
Yeah.
Very, very rarely about medium term or in a few years' time.
Yeah.
So I think that around metrics, the element of having a shared consequence, I think, is really important. So with my local authority colleagues, we both have a vested interest in our local communities, slightly from different lenses potentially, but we both want what's right for those as individuals. I think if we take something like delayed discharge as an example, and there was a pot of money that said, this is a baseline that the hospital has. This is the baseline of packages that the local authority deliver. Let's see a measurable shift in that, and that there is a consequence if there isn't a measurable shift, if money has jointly been put in.
Do you think in that case a stick would work perhaps better than a carrot? What kind of consequence also would you think would work in that situation?
I think there's something about being responsible back to the public.
The accountability measure.
The accountability measures. I think that there is something, and I probably would never be thanked for saying this, about you can't just keep spending money without there being something about, well, if it doesn't work, how do we stop it? And if you had to pull that back, would you think differently? So at the minute we give, don't we? And there's no taking back. But actually if you did something and it didn't work, you'd maybe think twice if you then thought, I'm going to have to give this back if it doesn't work. And I think that there is areas across the country who have good, there's some of the, which the panel spoke about previously, some very good working relationships with local authority colleagues to say, let's try something that's a little bit different, who've both got a will and a vested interest in trying to make a difference because they're part of their local community, to say, if we did this, could we show, both from a numbers point of view but also an outcomes point of view for the local population.
May I just come back, so on this specific point on safety, so I think, was it Anu, you said you were talking about the effect of, we've got a system where we're just focused on safety. I was recently doing a ride along with my Oxford University has a ambulatory team that diverts not just at the discharge end but actually working with South Central Ambulance Service to stop people coming in the first place, and they try and tout for business within the ED. So people come to the ED, but what they find is actually clinicians have a very safety first view, and the only safe care could be delivered inside a hospital, and they have gotten quite frustrated that clinicians themselves need reassuring by the system as a whole that actually there are other ways of doing this with really quite complex and amazing kit in people's own homes that deliver such enormous benefits, not least cost to the hospital itself, which is why the hospital's funding it, because it can see that it's actually helping not just quality of care but also cost of care. Does that ring true with your experience of this? I mean, do we need to, is there a job to do with the workforce here to get them to look at this differently? It's a very different way of working as compared to how they have been.
Yeah, so we've almost got that inbuilt experiment within the organisation because we are an acute and community integrated trust. So our community teams have spent a lot of time with our acute colleagues demonstrating to them what they can do in the community, because I think there is sometimes a misconception around exactly what you've said. Everything has to happen in the hospital versus actually no, there's an awful lot we can do, and there's an awful lot of risk that both primary care and our community colleagues hold in the community. We have invested as an organisation in virtual wards and hospital at home. So traditionally there are patients who we would support on our respiratory wards with respiratory kit. We now do that at home, so we have a respiratory hospital at home service. As part of that, as others can see, they gain faith in the fact that actually there is some of this that we can do at home. There's a lot of stuff that we used to do in hospital that we don't do that anymore. We do it out in the community, delivery of IV antibiotics, for example. Yes. Used to always be a hospital activity. We either now do that through ambulatory care or in people's own homes. There will always be a cost benefit on that. So because I've got quite a rural geography part of our patch, that's not always as efficient from a financial point of view in terms of the number of people the community staff can see in any given day. However, there is definitely a shift, I would say, about what clinicians feel they can do in hospital versus what can be done out in the community.
How easy is it to get into the local care homes? So the advanced clinician that I was with was desperate to get into the care homes and start there and help them to see that actually that when things get tricky and they're worried about safety, that actually their first port of call is not ED, but actually maybe to find another way in to their service. Do you have a good relationship with your care homes locally?
We do, and a lot of that was built, has been built over time. I would say it was possibly one of the during COVID in particular, there was some strong relationships with infection control teams,
Is that still there? Because a lot of places say that that's gone.
In terms of the relationships,
yeah.
No, the relationships are still there. I think we need to rebuild and re-educate because of the turnover of staff in terms of what options are available. So we have community matrons, for example, that feed who work out in the community and into those nursing homes, but who feed back into the organisation. We also have something called a single point of access service, which is a number whereby anybody out in the community can ring and can then direct or navigate people to the right
That's
part
separate to
of
111.
the system. Separate to 111. And linked to that is something called the 2-hour urgent community response, which again is somebody where as a care home, for example, you might ring that number and we can say we'll send somebody out within 2 hours to see, rather than sending that patient into hospital. Is that very well utilised? I would say it's a work in progress.
Yeah. A lot of these are nascent around the country, it would seem. And I just want to come to Isabel, because I know you had some things you wanted to say about integration.
Come in on both what Annie and Birju referred to, in terms of just thinking about what are the ingredients for successful integration and improving that. We know, as you said, it's nascent in some areas, it's going really well in some areas, but we know we've got to have the ingredients for success there. So I think colleagues have pointed to a couple of things there. One around that multi-year focus is really important, because you need, a lot of it comes back to relationships, as you said, relationships, that takes time to build that trust.
Local leadership?
Yeah, local leadership. I think having that time to really build those relationships, seeing that multi-year picture so you know what you've got to work with in a decent amount of time to be able to build something together in partnership and see the results through, and then improve it, adopt a continuous improvement approach to keep that improving, I think is really important. But at the moment, and I think previous panel talked about this as well, the sort of difficulty of that, not having that multi-year focus. So that is a challenge, we know. I would say though there are loads of good examples across the country where we know it is working really well. So South Warwickshire, for example, they've got a joint funding arrangement across the ICB, Trust, County Council, and that supports people with domiciliary care and therapy at home. So I think that's the type of example where we can see some of those levers that people can pull on, like the joint funding that Annie mentioned, but also then just thinking it's taken time to build those relationships over a number of years and really get that to a solid place. So I think that's just something we need to have in mind as we're thinking about the solutions as well.
Anna, can I ask you about the role of the ICB in sort of navigating the community, and we've also got in some parts of the country big trusts which hold all the money and hold very often a lot of the power. And then these sort of more disparate groups and the roles that the ICBs can play. I mean, in your from where you sit, how well is this working, and what could we what could we be doing better? But, you know, the cost of inaction, what is not happening because it's not quite working right is also, I'm really keen to hear about.
Yeah, so the Black Country, like Birju, actually, our 4 trusts are acute and community. So the problem that some other ICBs might have, we don't experience in the Black Country, which I guess why we feel that we're quite advanced in terms of our place models, that we know getting it right at place has got to be part of the essential ingredient to the solution, because the big shift, and I was really pleased that Birju, you talked about that kind of clinical appetite. For me, the biggest shift has got to be boldness of ambition. So we are, as a system, I think a health system, tinkering around transformation and trying to fix the model we've got, when actually what we need is a fundamentally different care model. And we kind of know that, and the new policy drivers are helping us move to that new care model. And some areas like the Black Country have kind of had that belief for a long time and now able to almost see the fruits of that. So, for example, we've built a brand new hospital. Really, really welcome the committee coming in and have a look at that model. It's a model that is almost unique in that it has a lesser bed base. So we know that the future of care is not in big, shiny hospitals. They have to be for those acute episodes where people most need to be in hospital. Instead, we've invested differently in community. So at the same time as that was being built, and one of the
Did
most...
the money for that come from?
Part of their kind of national programme.
I see.
But the real ingredient was the clinicians actually having the appetite and the bravery to say the community-based model is the one we are going to go to. Now, I was blown away by that, meeting our clinicians who actually were just forcing us almost as system leaders to say, come on, put your money where your mouth is. We know...
What level of clinicians were driving this? The ones who sit around your board? Or
the MMUH, the Midland Met. So the medical director, I've heard her speak many times about actually getting in there and corralling that community of clinicians, care professionals in every facet, and actually getting people excited about a different model of care, but also trusting in it. So your point, Birju, about actually clinicians are trained, forgive me, to be risk averse. Yeah. There is something about, you know, delivery of care rather than the co-production of care, which again is a big shift for the NHS. We're on the way, but we're nowhere near there in terms of co-producing care with patients and carers and communities themselves. But the big shift for us was actually investing in community provision, along with our local authority, along with our community sector, to make sure that almost the front door pathway into the new build hospital wasn't overwhelmed, because we believe in the new model. We believe in neighbourhood health.
Was the hospital leading in it?
Yeah. So that's kind of one example, and I guess I do work on a number of ICBs. So I work across South East London as well with 6 boroughs in ours, with some really, really big, so, you know, Guy's and St Thomas's, King's, Slam, you know, really big organisations. And, you know, just this last week I've been closely involved with something called the Lambeth Alliance, which is
Lambeth Alliance.
Living Well Alliance, sorry, which is, you know, Slam is a big mental health provider, but has the humility to work very closely in partnership with many pooled arrangements with voluntary community sector and the local authority to look at investing differently in prevention and making sure that whole pathway design is thought through, not just looking at managing exacerbations or moving people on to different settings. So it's possible to do, but it does take bravery, it does take time, and as you've said, it takes those relationships over many years.
So I'm hearing lots of good things about, as you say, the value of individuals deciding this is a priority, therefore driving the system to make this a priority, and then it happens. The problem is with that is that if we're trying to do this across the entire country, we then need to at some point quantify and codify actually what was the secret sauce. And, you know, having good people in place is not enough. We've got to do more. So if you were to try and distill it, as we're thinking, to a part of the country that perhaps is scared to do this or hasn't done this or feels it doesn't have the money to do this, what would that be if that's not too difficult a question.
If I may just
happy to throw that to everybody.
Yeah, if I may just come back. So I think a few years ago we didn't have the clarity around the policy drivers. So it isn't just the kind of Darcy report, but a number of
the drive from government itself.
And so people feel safer, they feel more comfortable. Very recently, the latest planning round in the NHS has come out, along with a model for neighbourhood health. You know, we haven't had that in the past.
Okay.
So some of the things that are coming out as expectations from government are incredibly helpful. But I would say that the ingredient has got to be that we look medium to long term across a life course of, you know, a few years even, along with our partners rather than different organisations.
Clear direction from government, long-term settlements. Birju, anything else?
Yeah, I think there's something about knowing what your local area actually needs. So there is a general view of, yes, let's move care into the community. I think that is probably felt by all acute trusts now, whether you're integrated or not. Gone are the days of wanting to suck everything into the
client level data would help with that.
So I think there's something about, we talk about neighbourhoods and we probably all mean something slightly different. So being really clear that if we are talking about shifting care into the community or moving to a neighbourhood model, what do you actually mean and what are you actually going to do? And then how do you scale that up enough to say, I'm going to move X out of hospital now, or that was being delivered in hospital, out into the community, so the resource needs to go alongside. And I think we possibly all talk about that in a slightly different way. So for my area, I'm working with both of my councils at the moment, just mapping out that let me understand between health and social care and primary care what already exists and what the need is within that whichever
as a hospital
locality
CEO, if the money went with it, and this is the really nub of it, right?
Yeah.
If the money was taken from you and given to the community because you could see it was the right thing to do, but actually your bottom line is going to decrease at that point, would you do that?
Yeah, if I don't need it anymore because I've moved that element of care, it's only right that the money follows with. Yeah. I think there is a balance in terms of it's the money, the here and now, so shifting the care in the people that already exist, and also thinking about the future, which was the point I made earlier, of it's also the preventative costs of having to build more hospital wards, etc. as well. So it's not just the here and now. I think the trick is how we get almost that double running cost of what do I do in the meantime while the next model is being grown and developed.
And if you have no extra money,
that's the challenge.
Do you choose that? Okay, but you don't have an answer.
Don't have.
Okay, just checking. Isabel.
Yeah, I think just building on what my colleagues said, I think we are seeing the green shoots of the policy framework sort of bringing that focus in terms of the shift to prevention, shift to community as well. But we do need to be realistic, but it will take time. So I think in terms of your question around what will help, it's having that nationally aligned framework for both health and social care and making sure that those are pointing towards integration, working well and getting the ingredients right. And we've got the 10-year health plan in progress. Great that that's got a 10-year plan focus, because that points to what Birju was saying about, it's going to take time to really shift the resources around to where they need to be. We've also got the KC review coming up, so I think there's a really important point for me there around the alignment between what those two pieces of work are doing and making sure that they are not doing things. They'll be doing things slightly in parallel, won't they? But they do need to be working together and looking at the different pieces across there. And then I think we've seen some green shoots this year in the planning guidance, as Annie said. We need that to shift over time as well. So the 3 shifts are really, really built into what all services in the NHS are being tasked with doing over a 1 year plus period. And I think, medium, long term, absolutely, that needs to be the focus. And then I was just thinking about data and digital as well. So digital transformation, really key part of...
What about it?
Wellbeing. I think the examples we've seen work really well, so lots of them come up today, but as Birju said, where people are really able to understand local data, what's going on, what do their local communities need. So we know that digital transformation would help with that in terms of being able to really.
Which bit of digital transformation?
I
That's
think
a big umbrella.
Can
you drill down into what exactly would you like to see that would help this?
I would say one example would be ensuring that health and local care partners locally are able to invest in really understanding their data around health inequalities, for example, so that they know what the needs are of that local population. They can put in place things that are going to help with demand
exist
over
already.
time. It not enough of it, I would say.
Okay. Thank you. I'm going to pass to Jen Craft now.
Thank you, Chair. I am going to just touch on the Better Care Fund and how that's utilised in terms of prevention or community work. We've picked up on some concerns that the Better Care Fund has been prioritised on sort of short-term issues affecting hospitals rather than being used for that kind of community prevention work that stops people from needing to access acute care in the first place or keeps them in hospital for longer. How would you, if you were able to completely redesign the system, how would you best spend Better Care Fund money in order to relieve some of the funding pressure on local authorities and to kind of what areas of prevention are crying out for having some of that money spent there?
Yeah, I mean, the BCF is absolutely part. The learning from the BCF is absolutely part of the solution going forward. So I think part of the answer here is what else is social care doing that we don't need to pull in the BCF to backfill some of that preventative work. So assuming that we have a different settlement for social care and assuming that doesn't suck money, as it sometimes does out of public health or other wider determinants work, then we can look at the BCF as a tool for that joint interface around intermediate care. Absolutely. At the moment, you're right. Because of the crisis management we're in, almost all the BCFs are tilted at getting flow fixed, which is not the right thing to do. It absolutely needs to be focused on strengths-based, community-led investment to help communities be more resilient so they don't have escalations of care. So we've got an example, like I talked about the Walsall example, really strong partnerships, but also because of the funding issue, there has had to be a decommissioning of falls prevention services, which the data just tells its own story. Went from absolutely high achieving now to the number of presentations through a fall has just gone exponentially the other way, and we can track that to the lack of a falls prevention service. So there is something just about not seeing the BCF in isolation as a fix-it fund, but what needs to be around the BCF in terms of community support, basic prevention, public health, so then you can together, as a health and wellbeing board, target your BCF locally at the things you need to. Because I don't think it can be a national solution, but the things around it need to be in place.
And so that relies again on local leadership being in place. How can government, how can the centre sort of incentivise local boards to take the action that you've just outlined?
Well, some of it again is around, so a number of the funds that were put into the BCF recently have actually been around discharge. They've been around winter. So that's a message in itself. So if government wanted to have locally empowered leaders with agency that can tilt into what their communities most need, we probably need to be giving money without the conditions attached to it, without the reporting attached to it, a bit more freedom around localities being able to use that investment. So for example, I work in certain areas where it's absolutely critical that we do something around black maternal health. Absolutely critical. Now, locally, we need to be able to tilt our spend into that kind of preventative work, working with the voluntary and community sector, trusted advisors to help shift that terrifying data. Now, actually, lots of our money is tied up in different streams and linked to very specific reporting we might have to do around UEC, around elective reform, around discharge, and it means that you as local systems, whether you're at ICB level or at place level or neighbourhood level or MDT level, you are caught up in conversations that perhaps you wouldn't want to be, but you have to be.
I'm probably going slightly off piece for what I've got written down here, but you've just said something that I think is incredibly interesting. So you say you have to do something on black maternal health. I think leaving aside the moral imperative, you've got data that shows that there are worse health outcomes for that particular group. Now, by have to, are you being driven either from the centre or from the oversight of your board to do this, or is this a local priority that you have identified?
Local priority, 1 in 4 maternal deaths. That's the data we're dealing with. We know we have to do it. In the Birmingham and Solihull ICB system, again, we know slightly different drivers, but neonatal mortality, some of the most shocking across Europe. We know we have to tilt in and do something slightly different with our funding. Now, as Birju said, I'm going to have to draw us back to the topic.
Sorry,
guys.
The committee is very interested in this and perhaps watch this space, but
it's mainly I was just in
local freedoms, I would say. Local freedoms to spend and tilt.
And I think that's my question was just where, can you where you're getting the pressure from, and I think the local ability to identify and take action is probably the key thing there. And just very quickly to touch on another large funding basis, continuing healthcare. So we've heard concerns from local authorities that there are ever-increasing stricter criteria on entitlement to continuing healthcare, which is in turn having a knock-on effect on local authorities' social care budgets and having to pick up more complex cases potentially than they would have done in the past. Is this a concern that you share? And if you do, how do you see that kind of reaching a resolution there?
I can sort of give a national picture, but I think there'll be important local examples. I think just in terms of the problems you've highlighted, they are a symptom of demand not being met overall. So I think that's where it's so important to be thinking about stability of the system overall and lack of action storing up further problems. So I think I'd see those issues as symptom of the broader instability and lack of funding in the system. But I think there'll probably be maybe local examples.
Yeah, I mean, it probably is an ICB issue. The tension you draw our attention to is just a fundamental one around the system being set up in an unhelpful way. So we are pitted to have difficult conversations with our local authority colleagues, which we don't want to have. And our relationships are not such that we should be having these conversations. We talk all day and set up our own local governance structures around partnership, around pooling, around understanding each other's drivers, around leaning into population health management, which is what we want to do, and yet the way the funding is set up kind of nationally, especially around 117 and CHC, means that we do have to have those conversations about who pays. And if you've read the guidance, NHS England got some good lengthy guidance called Who Pays. It is a question mark. We're always worrying about that question mark, who pays?
And if the budgets was pulled, which is what you were suggesting earlier might be one of the changes that would help, the quantum of the budget doesn't increase. So how does not having the difficult conversations fix this?
Well, local authorities, as was trailed earlier, have a statutory duty to set a balanced budget, and some of that drives behaviours I would just say in local authorities where you have to make your limited piece of string fit. So some things will become enormously not complicated, but they will become sources of contention because you don't want to have to spend that money, even though perhaps that package of care is the arrangements around that are best suited to one agency, not the other. But you are driven to save money. Similarly, NHS having to set your work within your control total means you want to present your budget as close to coming in as you possibly can. So you are forced to have conversations about where does that cost truly sit, and that's not a conversation that benefits the people at the heart of either of those funding streams. And we know that, and we're always trying to make sure that any debate or discussion does not impact care in any way. But it's an unnecessarily fraught piece of work.
Back to you, Jeff. Thank you. Ben Coleman.
All right, thank you. Yes, we'll take a moment to come in to pick these points up, because you've been talking a lot about the challenges facing social care, and you're talking about the challenges facing two different organisations, as it were, the NHS organisation, the local authority organisation, involved in this. Just the challenge that we've talked about already, how are they affecting, in social care and local authorities, how are they affecting or will affect your delivery, do you think, to deliver your ability to deliver the NHS's 3 shifts, into community, digital and prevention?
Yeah, I mean, I'll start off for kind of strategic piece. I mean, where I started the conversation, we aren't able to have strategic conversations. We are having crisis-based conversations around points of service intervention. What services can we put in place? What services can't? And actually, the fundamental issue for the NHS is the rising acuity, and you get less needy populations if they're happy, if they're supported well, if they're walking down streets that are safe, if their housing is good. And actually what I've seen in almost all the local authorities that I've worked with in the last decade or so is that pulling away from those universal services that make people safe and well, damp in homes, things like that. Just look at some of the data around damp in homes and exacerbations for our most vulnerable, from children to older people. So some of that tension that local authorities are feeling because of the underfunding of social care has such a knock-on effect, not just to those vulnerable people that are entitled to those social care packages or our delayed transfers, but the NHS will feel this for decades to come, that we are having to deal with people whose multiple long-term conditions are not supported in a timely way because your social care budget is so inadequate. We aren't able to invest in public health in the way that we should around smoking, obesity, healthy lifestyles. If I may just end quickly on, I think the data tells us that contributing to a healthy lifestyle, only 20% is NHS services. In fact, 40% is absolutely healthy behaviours. You then have the wider environment, and then you have kind of housing and things like that. So we know that the condition that social care is in is giving the NHS, if you would think of it in parochial terms, a long-term problem. We will never, ever have the investment to deal with the acuity that is growing and coming our way.
Interesting bit, Birju.
Yeah, I think that health and social care is inextricably linked. We have to do this together. So that shift of hospital to community, sickness to prevention, that's not a health thing. It's not a social care thing. We have to find a way of how we combine that. And I think the challenge that we have all got is this is going to take time. The sickness to prevention, just based on what you heard earlier on and what you hear now, that's not a 1, 2, 3 year fix. We're talking a much longer period of time. The hospital to community shift, I think, is really interesting, because I think that is, if we were bold and brave enough to say, let's just take the leap of faith. And I would say this, but if there is some bridging or some double running cost that could be put in to say, what is the art of the possible here? I think that is something that we should look to move quicker on. And I think within that, there, as with all of these things, there has to be a win-win. There has to be a win-win for health, and there has to be a win-win for social care, in that there will be things in the community that will help deliver some of the needs of the NHS that only social care can do, and it will be their statutory responsibility to do that. NHS needs to back off and stop thinking it can fix everything. That's leave that skill set to our councils.
What do you mean? What is NHS doing at the moment that would be interfering with social care unnecessarily?
So it's not per se, but it's rather than the NHS thinking it has to fix everything out in the community, it needs to say that actually the things that are relevant for be it housing, for example. That's a local authority issue. That's not, why the NHS necessarily commenting on that. That's a local authority know what they need to do.
For being challenging a little bit on that, but isn't the NHS commenting on the fact that, for example, housing, that our homes, too many homes are riddled with damp, which is causing problems for children throughout their lives and causing problems for hospitals, ultimately in the end. Isn't it reasonable for the NHS to comment on that if we're trying to reduce and prevent the problems?
Yeah, so sorry, I should correct myself there. It is to comment, but not necessarily to do. So the fixing of that housing issue is a local authority issue, and they are working in my patch. They are looking at that, they're working on that. It will have a benefit ultimately for the NHS. But similarly, in a way, there will be things in the community that the NHS can do from a pure health point of view that they need to focus on. And then there will no doubt be a subset in the middle that either one can lead on, that as long as somebody's doing it, it doesn't matter who. So I think that when I talk about the health and social care being inextricably linked, that's what I mean. So the fix of the wider community is something that we all have to do together.
I don't know if you want to add.
Yeah, so I think the interconnected nature of the two is really key here as well. I think also just thinking about the demand picture as well. So if we look at the research Health Foundation has done fairly recently, there'll be 2.4 million more people living with major illness by 2040. So we've got to be thinking about the three shifts in that context as well, about being able to address demand and what that future demand is going to look like. So we're ready to have done the three shifts by the time that demand is escalating. And I think there is a risk sometimes of focusing on quite narrow policy priorities. So we all know that elective care waiting list is absolutely crucial to address, but if we're only looking at that in a silo and not really looking at the issues we started talking about in terms of patient flow, delayed discharge, the knock-on effect on bed base, avoidable admissions, etc. If we're not looking at the whole picture, then there's a risk that we focus on that one thing but don't see the interconnected nature of all that working together. So that's the important part, I think.
I mean, we talked about the impact of, we talked about the lack of social care provision, which can have an impact on the NHS and the need to reform social care. But in my experience, and as Josh said, I'm one of these other people who has the scars on my back from being cabinet member for health and social care for a long time. The NHS we talked earlier about not understanding social care. The NHS often doesn't understand it. How do you think the NHS could reform to interact more effectively with adult social care? And what's the cost of the NHS not grasping this and not reforming to interact better with adult social care? To Birju, I can see you smiling away. Why don't you start with?
So the cost, I think I alluded to earlier on, in that we have to change. We've got an ageing population. A colleague here has already talked about the rise in acuity now. Some of the less acute presentations that we used to see, we don't really see anymore. And I think I've already alluded to in terms of the numbers, just by 2040, what that would mean in terms of a hospital service if we didn't do something different. And I think helpfully figures like that, when we talk about them, or when I talk about them internally, that's a real driver for a lot of our clinicians in terms of trying to say we absolutely have to now almost tip the model on its head and say, if we were about to do a complete turn, what would that look like? And that is a work in progress, I would say, around exploration. Sorry, I can't remember your second part.
The main point was what the NHS needs to do to reform itself so that it would interact better with adult social care, and what will the cost be if it doesn't do that?
Well, I think the cost is what I've said. How we reform, I think that is, and it is in the three shifts that nationally have been said. We've talked for a long time, and I would say over the past 10, 20 years, as long as I've been in the NHS.
Is it just reforming in terms of the three shifts? Is there a mental shift that needs to take place in the NHS?
It's both, I think, because we've talked about moving care more into the community for the past 10, 15 years. Arguably, you might say that now the external environment is right for it, whereas perhaps it might not have been previously. I think because of the pressure within the NHS now, the mind shift is absolutely there, and we should harness that mind shift now.
Yeah, just a last thought. So you're absolutely right about the mental shift. So the 3 shifts are absolutely right. The policy drivers are right. We're doing it. One of the biggest things we need to get right is actually the boldness to buy something different. So in commissioning terms, commissioners like integrated care boards need to buy preventative services. That's what we need to do. The buck is really here.
You have the skills to do that?
Absolutely. Going back to your data point, the data tells us that if you were to take a population health approach and you were to model the lack of certain interventions on things like growing hypertension, COPD, whatever it might be, they are the things that are swamping our system. Something like 70% of spend on long-term conditions and the presentations, more than that. So
would the commissioners be in this context?
Integrated care boards.
Integrated care boards. What about hospitals themselves buying preventative services, commissioning them?
Absolutely. I mean, the world of the commissioner provider split has long gone, so that's what the boards are now. They're working in partnership with all partners in the system. But where I think sometimes we can lead to inaction is
why wouldn't hospitals want to spend the money on doing that, given that it would cost? Why wouldn't hospitals want to spend the money on prevention locally and get a much more formal role in that, given the knock-on impact, positive impact for hospitals?
Is their commission to deliver certain things
We need to change
that are the acute? Yes. So if you go back and back and back.
If we did change that, are hospitals better placed than ICBs to do this, or ICBs better placed than hospitals in an ideal world?
Well, if you go back to where we want to be, which is population health improvement, if hospital leaders are the right people to be talking to local authorities and communities, they need to be the right people. At the moment, what we think having a leadership cadre that brings together clinicians, hospital leaders, local authority leaders, community leaders, voluntary community sector to actually focus on population health in the medium to short term. That's what the ICBs are set up to do.
Birju, would you have a view on that as well?
Yeah, no, I was just going to comment on the hospital's role in that as well. So locally we have something called Making Every Contact Count. So that public health element of prevention, of there is an evidence base that suggests, rightly or wrongly, when a clinician says to you, you now must stop smoking because this is going to happen to you, the person's more likely to listen rather than just when somebody else has been saying it or they've been watching the adverts, etc., or be that for alcohol or for whatever else, particularly when they've had an acute clinical episode. So we use that almost as an opportunity to educate when patients are in front of us. So it was just really the comment in terms of what can hospital services do here and now in terms of that prevention agenda.
Very much.
Well, thank you very much, all of you. That brings us to the end of our session. Order, order.